Hello, my name is Dr. Patrick Yachimski. I am a member of the Division of Gastroenterology, Hepatology, and Nutrition at Vanderbilt University Medical Center in Nashville, Tennessee. I'm very happy to spend a few minutes introducing you to our study titled Trends in Performance of ERCP Among Patients with Surgically Unresectable Pancreatic Cancer, a survival, epidemiology, and end results Medicare database study. My co-investigators and co-authors for this study are Amy Lucas from the Icahn School of Medicine at Mount Sinai in New York City, and Stacy Duzitsina from the Department of Health Policy at Vanderbilt University Medical Center and the Vanderbilt Ingram Comprehensive Cancer Center. And on behalf of my co-authors, I'd like to thank the editorial and production staff at Gastrointestinal Endoscopy both for publishing our study and for allowing us the opportunity to participate in this author video interview series. So let me give you a little bit of background regarding the rationale for why we chose to perform this study. My clinical practice is as a pancreatobiliary endoscopist, and one of my research interests is trying to understand how the use of interventional procedures such as ERCP and EUS has evolved over time in the context of changing treatment paradigms, changing treatment pathways, changing practice guidelines. Certainly as an example of how the role of ERCP can change over time, one need look no further over the past few years than the role of ERCP in the management of patients with surgically resectable cancers of the pancreas head, where data have suggested that patients who are able to proceed promptly to a surgical resection without preoperative biliary drainage may be exposed to a lower rate of adverse events, lower morbidity than patients who undergo preoperative ERCP or preoperative percutaneous biliary drainage. Data regarding the role of ERCP and how this has evolved over time in the management of patients with unresectable pancreas cancer, however, are much more limited. And this is the group we choose to focus on in this study. For this, we identified a cohort from the SEER-Medicare linked databases, which consists of Medicare claims data linked to cancer data in the SEER registry. This has been a fertile data set for researchers interested in clinical outcomes, in cancer treatment, cancer diagnosis, and cancer therapy. We identified in this cohort between the years 2001 and 2015 patients aged 66 and older who had complete Medicare claims, who had a histology diagnosis for adenocarcinoma of the pancreas head, who had undergone an ERCP on the basis of procedural coding claims data, and who had never undergone a pancreatic surgical resection based on coding and claims data. We restricted the cohort to patients who survived at least 30 days following cancer diagnosis to avoid a mortal time bias, and that's further described in the manuscript. And we also defined receipt of ERCP for pancreas cancer as ERCP performed within the 30 days before up to 30 days after cancer diagnosis. And we identified 14,000 subjects who fulfilled all study inclusion and exclusion criteria, so a fairly robust data set. In our view, there were two important findings of our study. The first was that the proportion of patients in this cohort diagnosed with adenocarcinoma of the pancreas head who underwent ERCP on an annual basis declined over time from 57% of the cohort in 2001, steadily declining to 46% of the cohort in 2015, and that was a statistically significant decrease. Now, to me, what that means is that we are being increasingly considerate and discriminate as to how we're using ERCP in patients with surgically unresectable pancreas cancer, and using ERCP in cases only in which it is the appropriate and next necessary step in the patient's cancer care, and not as a knee-jerk reaction to a tissue diagnosis with cancer or an elevated bilirubin level, or a CT showing biliary dilation. Now, one of the limitations of the Medicare data set is you can't get to granular clinical decision-making level data. So we don't know in all cases whether avoidance of ERCP was pursued because the oncologist was able to choose a different chemotherapeutic regimen that didn't require biliary decompression, or whether it was due to patient preference to avoid an invasive procedure. But nonetheless, I found this data to be quite encouraging, suggesting that we are using our cognitive decision-making skills in deciding how to best manage patients, not just as proceduralists using these procedures indiscriminately. The second important finding was that among patients who underwent ERCP, the mean number of ERCP per patient from the time of cancer diagnosis to death also decreased significantly over time, from 2.3 ERCP per patient in 2001 to 1.8 ERCP per patient in 2015. This was also statistically significant, and I would argue clinically significant, subjecting a cancer patient to fewer procedures, fewer exposures to the risks of the ERCP, fewer exposures to anesthesia, can only be to the benefit of the patient. We have speculated that the reason for this finding is the more prevalent use of fully covered self-expanding metal stents rather than plastic stents, which require less frequent, either scheduled or on-demand stent changes due to longer durable patency rates. This hypothesis is not testable in this cohort because there are not distinct procedural codes for metal versus plastic biliary stents. So this is certainly something that would require further investigation. Despite the fact that fewer patients with surgically unresectable cancer of the pancreas head are undergoing ERCP, and that among patients who undergo ERCP, fewer ERCP are performed per subject, over the time period of this study, 2001 to 2015, survival improved, consistent with modest improvements in survival of pancreas cancer patients as demonstrated in other data sets. We hope that this study will provide those of us who perform ERCP an opportunity to reflect on the role of ERCP in our care of pancreas cancer patients and provide an opportunity for new research endeavors in this area. I'm happy that you were able to spend a few minutes talking with me or listening to me this afternoon. I'd welcome your comments, feedback, criticisms, and suggestions in any dialogue that you may have. Thank you.